Good evening, everybody. We are going to start the session for gynecologic cancer. In this session, we'll have three presentations. The first one will be held by Dr. Ahmed Magdi, Professor of Medical Oncology in NCI. He will give us a talk about when to do the test for PARP inhibitors.
Thank you so much for the good, excellent presentation. Thank you for inviting me. I'll be quick. Can I have my slides, please? Yes. So how to make the test of PARP inhibitors, when, how, and who. So these are my disclosures. So as a basic, we know that DNA is in constant damage and repair. So we do have a single strand break. We do have bulky adducts, base mismatch, and DNA double strands. So if we did not treat the DNA single strand break, then it will lead to a double break. And this is very important to understand why do we do the BRCA testing and how to target that. So in order to repair a single strand break, we do a base excision repair. For the bulky adducts, we do nucleotide excision repair. Base mismatches, we do mismatch repair. And for the DNA double strand, we have two pathways, the non-homologous end joining, which is not our main repair mechanism. And we do have the homologous recombination repair, which is our main repair mechanism. So the proteins responsible for that, for the DNA single strand, we do have the PARP. Hence, we now have the PARP inhibitors. For the bulky adducts, we do have the ERCC1 and ERCC4, MSH2 and MLH1. We all know that from the colon. And for the double strand break, we do have the homologous recombinant repair mechanism, which includes many genes, the BRCA mutations, the BRCA mutations, the PUL-B2, CHEK1 and 2, and RAD51. So for the PARP, to repair the single strand, it attaches to the single strand break, leads to the NAT positive change to polyadipose ribose sugar, and then leads to more bringing of repair mechanisms, and then we have the DNA repaired, and then we get rid of these PARP. This is the normal mechanism we all have in our body for the single strand break. However, if I can block this repair mechanism and keep the PARP attached to the DNA, it will lead to double strand break and DNA damage and cell death. So in normal cells, there will be a repair of the double strand DNA breakage through the homologous repair recombination. However, in HRR deficient cancer cells, the cells will die. So if I block the PAR pathway with HRD deficiency or homologous repair deficiency, then we can have cancer cell death and control. And we all know the Angelina Jolie effect, which was very important in breast cancer, where she announced that she has the BRCA mutation and underwent prophylactic mastectomy, and later on she did prophylactic oophorectomy. What about the germline BRCA mutation? Of course, we do have germline, and it's very common in breast, ovarian, prostate, and pancreas. And this is why now we can somehow control these malignancies, and let's see how we do that later on. For ovarian cancer, for the BRCA1 mutation, it's 8%. I'm sorry for the mouse, it's not me. I know it's very confusing, but this is not me. So 8% for the ovarian cancer, which is BRCA1, 7% in breast cancer, pancreatic is 1%, and prostate is 1%. So now again, we understand why we do have very strong data in ovarian malignancies and breast malignancies. It was also found that the BRCA mutation is not only present in specific malignancies, but also has a geographic and ethnic variety. So for the Ashkenazi Jewish, of course, and phenotypical BRCA mutations and so on. How we do the testing? First of all, we do a sample preparation, pathology review, we extract the DNA, and then we do the NGS, next generation sequencing, which yielded a lot of data. And now we have we are now in the era of the precision medicine. And for those of you who attended the ESMO or read about the ESMO 2022, it was all about precision medicine. And we're over now one size fits all for the management of our patients. So first of all, we start by blood testing to look for germline mutation. Why are we looking for germline mutation? Because it's more common than the somatic mutation. However, if we do the blood test and we find that there is negativity for BRCA, this doesn't mean that the patient doesn't have BRCA mutation on the tumor itself. So we have to go for the somatic mutation. So we start by germline and then we do the somatic mutation. The advantages, of course, blood test is a non-invasive technique, very simple, can be performed anytime. However, it cannot define or identify the somatic mutation which could be present on the cancer cells itself. For the tumor-based testing or the somatic, the issue was to obtain a biopsy from the tumor itself, of course, but it allows more identification if we do have a negative germline. I'll go quickly, and this is here to show you that when you do the blood, you can only find 15% of the BRCA mutation. For the HRR mutations, you get 23%. However, if you do both the germline and somatic, with the genomic instability, you can get up to 50%. So this is why it's important to know how to test and when to test and who to test. And if you looked at the NCCN guidelines, yes, these are 2020, but it hasn't changed. For patients treated with 3 or more prior chemotherapies in ovarian cancer, a deleterious or suspected BRCA mutation should be done. Genomic instability and progression more than 6 months, you have to look for that. So we all heard about the SOLO-1 trial, which was olaparib maintenance after newly diagnosed patients who achieved a CR or a partial response. We gave them maintenance of olaparib versus placebo, and we all know the progression-free survival. As you can see, the beautiful early separation of the curves with an excellent hazard ratio of 0.3, so 70% response regarding the progression-free survival. And if you go on and look at the longer follow-up, the 2-year treatment, and then you go for the 4-year and more, you will find still you are maintaining, even after stoppage of the maintenance treatment, you still are gaining a better progression-free survival. 5-year follow-up, again, as you can see, the high risk, of course, gets the benefit, and even in the low risk, you still get the better progression-free survival. What about the overall survival, which was announced this ESMO? It showed us that there is an overall survival with the maintenance for the SOLO-1 trial, and you can see here the hazard ratio of 0.55, and it is statistically significant. So you do get an overall survival with using the maintenance of PARP inhibitors or the olaparib. What about the Paula one? The Paula, as we all know, is first line, whether surgery and platinum taxane based with bevacizumab, and then you give maintenance with olaparib and bevacizumab versus placebo and bevacizumab. Progression-free survival, again, you can see there is an improvement of 7 months with a good hazard ratio of 0.59. And progression-free survival, of course, by BRCA mutation, you'll get the best response with the presence of BRCA mutation. HRD positive, yes, you still get with BRCA mutation or excluding BRCA mutation. However, in HRD negative or unknown, we have zero benefit with the addition of the olaparib. Sorry for that. For the overall survival, which was again announced this ESMO, and I would like to thank Professor Mohammed Yassin for supporting me in obtaining these slides actually right after the ESMO. So if you look at the overall survival, you will find that again, for the 5-year, yes, you still get an overall survival with the addition of olaparib, and you get a hazard ratio of 0.62. So it's a no-brainer now for the ovarian cancer. If we do have a mutation, whether the BRCA mutation or the HR deficiency, we must use the PARP inhibitors. I'll go quickly for the sake of time. Now we go to the breast cancer. We've been talking about ovaries. Let's look at the breast cancer. And we all heard about the Olympia trial. If your patient is triple negative and we gave them neoadjuvant, or even if hormone positive and still having more than or equal 4 lymph nodes, we give them the olaparib maintenance for 1 year for those BRCA mutant. And for the intention to treat population, you get an invasive disease-free survival, which is statistically significant with a hazard ratio of 0.58. Again, this is the increased follow-up. And again, distant disease-free survival, you still get a benefit of about 7%. Overall survival, yes, it's a little bit, yes, it's there, statistically significant, not that impressive. Maybe with the longer follow-up, we can get a better outcome for those patients. I'll go for the sake of time. I'm sorry. Now, if we go for the prostate cancer, remember we said that the BRCA mutation is not present as high as the ovary or the breast. However, when we use the PARP inhibitors, the olaparib in those with BRCA mutation, yes, you still get a progression-free survival, which is statistically significant, yet not that impressive of only 4 months. But if you look at the subgroup analysis, you'll find that all are in favor of the olaparib arm. Again, confirmed overall response rate. As you can see, the difference in those diagrams, you'll get a 2.3% versus 33%. You're talking about a 31% overall response rate, which is really good. And then time to pain progression. So you get a good quality of life and pain control with the addition of the olaparib. Overall survival, there is a trend, yet yes, it was statistically significant with a hazard ratio, acceptable hazard ratio, and a gain of almost 3 months in overall survival with the usage of olaparib in prostate cancer with those with BRCA mutation. And thank you so much for listening.
Thank you, Dr. Ahmed Magdi,
Thank you.
for elegant presentation and thorough knowledge. Questions? Any questions?
Okay.
Postpone
Okay.
after.
Thank you.
Thank you. Now, Professor Muhammad Abu Futuh introduce is immunotherapy ready for prime time in cervical cancer?
بسم الله الرحمن الرحيم. أولاً I would like to thank the organizing committee for inviting me to talk about this subject. My talk is immune therapy ready for prime time in cervical cancer. These are some facts about cervical cancer. It's still representing a major public health problem with more than 600,000 cases worldwide every year, with more than 300,000 cases die from the disease. In Egypt, it ranks number 20 among other cancers, with 1,320 cases, new cases per year, and 744 deaths per year. This is unacceptable, particularly if we know that we have prophylactic human papilloma virus vaccination and early detection of pre-invasive disease several years before it becomes invasive or metastatic. So it's a shame to have this problem while we have these tools. Hopefully we will start soon in Egypt to do the vaccination and the screening within few months, inshallah. Early stages, as you all know, is cured by radical surgery or tailored adjuvant therapy. Patient with locally advanced disease treated with chemoradiation, with brachytherapy, with a 5-year disease-free survival and overall survival of 45 to 80%. However, the management of women with recurrent disease who are not candidate for pelvic exentration and those present with metastatic disease has a dismal survival with few months overall survival and represent an unmet clinical need for decades. Chemotherapy for metastatic cervical cancer, the treatment evolved through a number of GOG studies The first compared doublet cisplatin paclitaxel versus cisplatin, and it was in favor of the doublet. Then we have another doublet cisplatin topotecan versus cisplatin. Again, it was in favor of the doublet. Then we have comparison with 4 different doublets compared with cisplatin paclitaxel, and this study was closed early because of fatality, as cisplatin and paclitaxel was superior to other doublets. And we have a JGOG study showed carboplatin and paclitaxel is non-inferior to cisplatin and paclitaxel. Then we come to the standard of care, the previous standard of care. This come from the GOG 240. In this study, they have cervical cancer stage 4B or recurrent or persistent after treatment with measurable disease, no prior chemotherapy for recurrence. The primary endpoint was if BEVA added to chemotherapy improves overall survival. The secondary endpoint was progression-free survival and the overall response rate. They compared cisplatin paclitaxel and non-cisplatin protocol topotecan plus paclitaxel plus or minus BEVA. This is the overall and progression-free survival. It was in favor of adding BEVA to the chemotherapy. Both it showed significant results, and again, it was significant for cis-paclitaxel, but it wasn't significant for topotecan paclitaxel. This is the second line treatment options for recurrent cervical cancer. Please note that the overall survival at maximum it will be around 8. The overall survival for second line at maximum is around 8 months. Then we come to the immune therapy, the rationale behind using immune therapy in cervical cancer. First, cervical cancer is virally driven, and most viral infection viruses have many ways to evade the immune system. Also, we have PD-L1 is not expressed in normal cervical tissue, but is overexpressed in squamous cell carcinoma, 19 to 88%, and in adenocarcinoma around 14%. Also, patients with negative lymph nodes have higher number of intraepithelial CD8 cells than positive lymph node. And third, cervical cancer has increased the tumor mutational burden rate with it's about 5 to 6 mutations per megabase behind melanoma, lung, bladder, and esophageal cancer and colorectal cancer. Increased tumor mutational burden lead to presence of more new antigens that can stimulate the immune system. These are the phase 1 and 2 immune checkpoint inhibitors trials in cervical cancer. We have the Keynote 158 and Checkmate 358 and balstilimab study. They use this in patient treated for the first 2 studies. They have patient received up to 3 lines of chemotherapy, while the balstilimab study, it was only most of the cases received 1 line of chemotherapy. The overall response rate for the pembrolizumab was 14.3, while for Nivo it's 26%, and for balstilimab is 15%. You can see here that for Nivo and balstilimab, there is responses in PD-L1 negative cases, while for Pembro, there was no response at all for cases with with CBS less than 1. The overall survival for the Pembro is around at 6 months was around 75.2%. For the checkmate, it is 21.9. This is significantly better than the chemotherapy study. As I mentioned earlier, it was around 8 months only. Then we come to the phase 3 study. This is the Empower Cervical 1 GOG study. They compared Simbelimab 350 milligram compared to the physician choice of chemotherapy. Patient received either Bemtrexate, gemcitabine, topotecan, irinotecan, and vinorelbine. The included patient was recurrent and metastatic cervical cancer resistant to platinum-based chemotherapy with more than or equal to 2 lines of chemotherapy. The primary endpoint was overall survival. Secondary endpoint was progression-free and overall response rate and duration of response and safety. You can see here this study is just updated in the last ESMO with Anna O'Cannon presented it. It showed that overall survival was 11.7 months versus 8.5 months for the chemotherapy. This is for the overall population and also was significant for the squamous cell population with 10.9 months versus 8.8 months with hazard ratio of 0.69. Again, in this study, the BDL1 status didn't affect the response to Simbelimab. And you can see here that at 12 months and 24 months, the Simbelimab was better or have a better survival compared to chemotherapy, regardless of the BDL1 status. And this is the safety profile. You can see here that the side effects and safety profile was in favor of the immune checkpoint inhibitor compared to the investigation choice of chemotherapy, with all the side effects were more common in the chemotherapy arm. Then we come to the first line, and we have the keynote 826 study compared Pembro plus chemotherapy versus chemotherapy and placebo. In this study, they add Pembro to paclitaxel cisplatin or carboplatin plus or minus Beva. Beva was not mandatory in this study compared to paclitaxel, carboplatin or cisplatin plus or minus Beva and placebo. This is the first line. This patient should, they have received no prior systemic therapy for the metastatic case. In this study, you can see here the progression-free survival was in favor of adding pembrolizumab to the chemotherapy with 10.4 months versus 8.2 months. This was true for the CBS more than 1 and for the intention to treat population, as well as for the CBS more than 10, almost the same results. You can see on the left-hand side, the forest plot, the only subgroup that didn't benefit from adding Pembro is a patient with CBS less than 1. Overall survival was there was similar results for the CBS more than 1 and intention to treat population, and also for the patient with CBS more than 10 with a hazard ratio of 0.61 and was significant. Again, the forest plot showed it favors the Pembro arm except for the patient with less than CBS less than 1. Then we come to this study. This is it has a similar design to the keynote study, the PCC trial. In this trial, platinum and paclitaxel plus Beva was compared to the similar protocol to atezolizumab. This study, the Beva in this study was mandatory, so all patients received the Beva. This study closed recruitment in August 2021, and the result is awaited. We have another trial with same design we're studying the BCD 100, which is anti-PD-1 in combination with platinum-based chemotherapy, with or without BEVA in first-line treatment. Again, this is ongoing study. We have other immune therapy strategies. These three studies the anti-BD1 or BDL1 Nivo and Plastilimab plus or the anti-CTL4. The first one study Nivo plus IBI, and the second one Plastilimab plus Zalifrelimab, which is anti-CTL4, either in combination or every treatment as a monotherapy in the second study. These studies are ongoing. Then we come to our question. Is immune therapy ready for prime time in cervical cancer? In my opinion, it's yes. And this is because the combination of platinum paclitaxel, pembro, and BEVA has shown superiority in terms of progression-free survival and overall survival for over platinum and BEVA in the first-line therapy for persistent or recurrent metastatic cervical cancer. And this has EMA and FDA approval for patients with combined positive score more than 1. For second-line, cemiplimab is first immune therapy agent to demonstrate significant and clinically meaningful overall survival benefit as a second-line monotherapy for patients with recurrent or metastatic cervical cancer previously treated for platinum-based chemotherapy but without prior immune therapy. It should be the new standard of care after failure of platinum therapy. Today, cemiplimab has been approved in Canada and Brazil regardless of BDL1 status. And this is the NCCN guideline, the last version. You can see here for first line treatment option, Pembro has been added to cisplatin paclitaxel plus or minus BEVA as a category 1. And this is my last slide, and thank you for your attention.
Thank you, Dr. Mohammed, for your side presentation. Any questions? Okay. Okay, we'll keep the questions for the end. Now, my dear friend and our colleague, Dr. Mohammed Yassin, will talk about the management of metastatic endometrial cancer application of the latest guidelines.
My presentation will be management of advanced and metastatic endometrial cancer application of the latest guidelines. Endometrial carcinoma has a rising incidence and mortality, and personalized treatment will improve the outcome. Endometrial cancer survival by stage. Most patients are diagnosed with early stage disease when the cancer is highly treatable, although less frequent survival rates in patients diagnosed with distant diseases are low. Until recently, treatment options for patients with recurrent or metastatic endometrial cancer remained limited. The backbone of first-line treatment, as we all know, is platinum doublet, usually based on carboplatin and paclitaxel. There was no standard of care second line after platinum failure, and single-agent chemotherapy, example with paclitaxel, doxorubicin, or any hormonal therapy with median overall survival was less than 12 months. So there was an unmet need, and IO or immunotherapy emerges as a potential game changer in the management of endometrial cancer. Also, HER2 is an actionable biomarker in patients with endometrial cancer. HER2 overexpression is seen, and gene amplification is seen in around 25 to 30% of endometrial cancer. And HER2 positive status in endometrial cancer is associated with response to target therapy, trastuzumab. We have seen that there was no difference between paclitaxel and carboplatin doublet versus carboplatin and paclitaxel and doxorubicin, with increased toxicity for the triplet therapy. Addition of trastuzumab to paclitaxel carboplatin in HER2 positive endometrial cancer has led to an improvement in hazard ratio of overall survival to 0.58. The classic endometrial subtypes were endometrioid type 1 and non-endometrioid type 2 which includes serous clear cell undifferentiated, including carcinosarcoma. Was this enough? Unfortunately, this old classification has been used for the past 3 decades, but they didn't fully capture the wide range of clinical, genetic, and molecular characteristics of endometrial cancer. And here we see the importance of the new integrated molecular classification of endometrial cancer. We have 4 subtypes. We have the ultra-mutated poly, and we have the hypermutated MSI high, and we have the copy number low or non-specific molecular subtype, and we have the copy number high. If we look at the outcome of the Tcga molecular classification, the best outcome is for the poly mutation. The second is for non-specific molecular subtypes. The third is for MSI high, and the worst prognosis or overall survival is for p53 abnormality or p53 mutation. Here is the new guidelines for molecular analysis. If you have a patient with endometrial cancer, first you have to test for poly sequencing. If there is hotspot mutation, it is poly positive. If no poly hotspot mutation, the second one you have to test for DNA mismatched repair protein immunohistochemistry. If expression lost, then it is MSI high. If expression retained, you have to check for p53 immunohistochemistry. If it is normal or wild type pattern, it is copy number low. If it is apparent or mutant mutation, it is copy number high. So this is the new principles for molecular analysis of endometrial cancer, which will impact our treatment decision in the future in the metastatic setting, and I will show you also in the adjuvant setting. So the impact of molecular classification, it has an impact on prognosis, it has an impact on risk categorization, it has an impact on personalized treatment. Endometrial, here, the molecular classification, we have the 4 subtypes. The poly ultra-mutated, ultra-high somatic mutation frequency represents around 7% of endometrioid tumors, and it has the best prognosis. The MSI hypermutated, high mutation rate and few copy number, it represents around 39% of endometrioid cancer. The copy number low, which was in the past named as the endometrioid type 1, high frequency of mutation in CTNB1, KRAS SOC17, it represents around 49% of endometrioid tumors, and the copy number high or p53 mutation, greatest transcriptional activity, and it has the worst prognosis and represents around 9%. Mutation and biomarkers in hot tumors, the poly ultra mutated and the hyper mutated group. Characteristics of both is high new antigen load, increased tumor infiltrating lymphocytes, high expression of PD1 and PD-L1. Concept of definition of MSI or mismatched repair deficiency. Definition of microsatellites is repetitive DNA sequences distributed across genome, particularly sensitive to DNA mismatch errors. MSI is a marker of mismatched repair deficiency and characterizes a hypermutable state of cells. The presence of MSI represents phenotypic evidence that mismatched repair is not functioning normal. Endometrial cancer is the 9th tumor as regarding highest tumor mutational burden. The management implication for poly mutation from the meta-analysis had shown that adjuvant radiotherapy was not associated with outcome, and we can de-escalate our treatment in poly because it has the best prognosis. While for mismatched repair deficiency endometrial cancer, it has high radiation sensitivity, low chemosensitivity from the Prostate trial. It has a response to hormonal treatment, and also it is the best as regarding immune checkpoint inhibitor. For p53 abnormality, it is the highest chemosensitivity of the 4 groups, includes HRD with implication for PARP inhibitors, and we have trials now in metastatic endometrial cancer with p53 mutation with patients who will receive PARP inhibitors as maintenance treatment. The best one is the non-specific molecular subtype endometrial cancer, and this was the one who was responsive to hormonal treatment. Where do we stand with checkpoint inhibitors in endometrial cancer as monotherapy? We have trials with avelumab, which is an anti-PD-L1, and anti-PD-1, pembro, nivo, and dostarlimab. Pembro and dostarlimab have been approved for patients with unresectable or metastatic MSI high deficient mismatch repair or tumor mutation burden high solid tumors that have progressed following prior treatment and who have not satisfactory alternative treatment option. The story started with the keynote agnostic trial 158 in MSI high endometrial cancer cohort. Patients will receive Pembro 200 milligram every 3 weeks until progressive disease or unacceptable toxicity for 2 years. And we see here a high overall response rate in second line, which was 48%. This is a safety profile of Pembro in the keynote 158 was consistent with the previous study. The famous Garnet study, which was also an agnostic trial, here we see an objective response rate of 46% and disease control rate of 59%. For patients with who have received deficient mismatch repair, who have received 1 prior line, the objective response rate was 50%, and if have received 2 more prior lines, it was 35.9%. Here, if we look at the waterfall plot, if the patients in the Garnet study have received 1 prior line of treatment, 88% of the patients remain in response. If more than 2 prior lines of treatment, 93% remain in response. The safety profile, there was only 1% report of grade more than 3 treatment-related colitis and no reports for grade more than 3 pneumonitis. And no deaths were attributed to the durvalumab. Another trial is the FEDRA trial of durvalumab with 2 cohorts, cohort 1 and cohort 2. Cohort 1 was mismatch repair proficient and cohort 2 mismatch repair deficient, and patients have received 1 to 3 lines and are certified to receive durvalumab 1,500 milligram every 4 weeks. And the response rate was 43% overall patients with mismatch repair deficiency, 52 in first line and 31% in second line. Another trial is with avelumab. Again, here we have, it is a phase 2 trial, cohort 1 mismatch repair deficient and poly-mutated, cohort 2 mismatch repair proficient and non-poly-mutated, and will receive avelumab 10 milligram per kg every 2 weeks until progressive disease. The 6 months progression-free survival in the mismatch repair deficient cohort was 40%. Overall response rate was 26.7%, and as regarding safety, 19.4% rate of grade 3 treatment-related adverse event. Here we are talking about the rationale for combining anti-VEGF and anti-PD-L1 and also to add chemotherapy. Anti-VEGF leads to differentiation of dendritic cells, depletion of myeloid-derived suppressor cells, and increased infiltration and activation of CD8, while anti-PD-L1 leads to increased infiltration of CD8 and CD4 and lead to inhibition of tumor-associated macrophage. While the microenvironment without chemotherapy, it is immunosuppressive, while adding chemotherapy lead to an immune-reactive tumor microenvironment. So here is a summary of the combination of checkpoint inhibitors in advanced recurrent endometrial cancer. In third line, we have the keynote 146. In second line, we have the keynote 775. In the first line, we have the LEAP-001, Pembro plus lenvatinib. In second line, we have Nivo plus cabozantinib, and we have ongoing trials, checkpoint inhibitors plus chemotherapy, Pembro plus paclitaxel carboplatin in first line, the ATTEND trial, Atezo plus paclitaxel and carboplatin in first line, and the RUBY study, dostarlimab and chemotherapy. The keynote 146 endometrial cancer cohort, patients are randomized to receive lenvatinib 20 milligram per day plus Pembro. We have 3 cohorts, cohort 1, not MSI or mismatch repair deficiency, cohort 2, MSI high and mismatch repair deficiency, and cohort 3, MSI and mismatch repair not available. The overall response rate in total was 38%. For not MSI or mismatch repair deficiency, 36.2. For MSI high, definitely high, it was 63.6. Here, if we look at the waterfall plot, maximum tumor shrinkage more than 0% was seen in 85.7% of the patients, more than 50% in 31%, and more than 75% in 15.5%. Endometrial cancer cohort progression-free survival by MSI mismatch repair status. For MSI high, it was 18.9. For MSS or proficient, it was 7.4. Overall survival was not reached for MSI high, while for MSS or proficient mismatch, it was also significant. It was 16.4 months. This is the adverse event profile as reported for lenvatinib plus pembro. This has led to the approval of pembro plus lenvatinib for advanced endometrial cancer that is not MSI high or deficient mismatch repair as second-line therapy. Here is the keynote 775, and we are waiting for the result. This is the phase 3 second line trial to compare the efficacy and safety of lenvatinib plus pembro versus treatment choice. Again, the same certification as the third line study, which was the keynote 146. Here, patients will receive lenvatinib plus pembro versus doxorubicin or paclitaxel. As regarding progression-free survival in the proficient mismatch repair, it was 6.6 versus 3.8. For all comers, it was 7.2 versus 3.8. For overall survival, for all proficient mismatch repair, it was 17.4 versus 12 months. For all comers, it was 18.3 versus 11.3. The exploratory analysis of deficient mismatch repair population, here we see a very high overall survival, which was not reached, versus 8.6, and progression-free survival, which was 10.7 versus 3.7. Treatment exposure and safety and discontinuation all comers. So the FDA grants regular approval of pembro and lenvatinib for advanced endometrial cancer that is not microsatellite stability or mismatch repair deficiency who had disease progression following prior systemic treatment in any setting. Ongoing trials, which is the LIB-001. Here we have moved pembro lenvatinib to the first line in comparison to paclitaxel and carboplatin, and we are waiting for the results of this trial. This is the first line trial, and we have also another second line trial of cabozantinib and nivo. And here we summarize the ongoing phase 3 trials with immunotherapy combination advanced endometrial cancer. We have the NRG GY 018 trial in which patients in first line will receive carboplatin paclitaxel plus pembro versus carboplatin and paclitaxel and placebo, and we are waiting for this result. We have the ATTEND trial, the same study design, paclitaxel carboplatin plus atezo versus paclitaxel carboplatin, and we have the RUBY study, which is a very important study of dostarlimab plus chemotherapy in recurrent primary advanced endometrial cancer, and one of the arms uses dostarlimab as maintenance, and one other arm dostarlimab plus niraparib PARP inhibitor as maintenance versus placebo in both two arms. The DUO trial is a very important trial of carboplatin paclitaxel in combination with durva, followed by maintenance durvalumab with or without olaparib in patients with newly diagnosed advanced endometrial cancer. So a very important question is, will checkpoint inhibitors replace chemotherapy in the front-line setting of deficient mismatch repair endometrial cancer? We have the Dominica trial of mismatch repair deficient endometrial cancer patient comparing chemotherapy alone versus dostarlimab in first-line advanced metastatic setting. And we have also the keynote in GOT 15, pembro 400 milligram versus carboplatin and paclitaxel. And here is the guidelines for endometrial carcinoma. And as we all know, still the standard of care until the results of the trials which I have shown you, the standard of care is carboplatin paclitaxel with other regimens, while for second line in recurrent or metastatic disease biomarker-directed systemic therapy, for second line, we have lenvatinib pembro for non-MSI deficient mismatch repair deficiency, and pembro for tumor mutation burden high, and also dostarlimab and also larotrectinib and entrectinib. Here are the second line hormonal therapy. We have trials ongoing with CDK inhibitors plus letrozole. We have everolimus and letrozole, and we have the standard aromatase inhibitors and fulvestrant. Here, I will give you a few slides on the future. The new molecular subtypes is not only for metastatic setting, and we have a very beautiful design study, which is the Rainbow study, refining adjuvant treatment in endometrial cancer based on molecular feature. We have 4 arms. The first arm is P53 abnormality, and patients will receive either chemoradiotherapy or chemoradiotherapy plus olaparib. The second arm is the mismatch repair deficient, and here patients will receive radiation therapy versus radiation and durvalumab. The third one is non-specific molecular subtypes. We receive chemoradiotherapy or radiotherapy, then hormonal treatment alone, and the poly mutated, which is the best subtype. And we can, if we know that our patient is poly mutated, we can omit adjuvant treatment, and we do de-escalation of our treatment. And we have also WEE1 inhibitor adavosertib, and a very important trial which was presented recently. For the first time, we are talking about maintenance treatment in endometrial cancer through inhibition of XPO1, which is a nuclear transport protein upregulated in many cancers and mediates transport of tumor suppressor protein and oncoproteins from the nucleus to the cytoplasm. And here we have the Siento trial, which is a very important trial. Patients who are in stage 4 or first relapse and have achieved a partial response or complete response after prior taxanes and carboplatin are randomized 2-to-1 to receive selinexor 80 milligram oral every week, 60 milligram per week if body mass index is less than 20 until progression versus placebo. Here we see that progression-free survival for all comers was 5.7 versus 3.8, but for serous it was 3.8 versus 3.7, and the endometrioid subtype, the best median progression-free survival was 9.2 versus 3.8, and in wild type p53 tumors, which are the non-specific molecular subtypes, here we see a significant median progression-free survival of 13.7 months versus placebo 3.7 months. And now a phase 3 randomized controlled trial of selinexor limited to patients with wild type p53 tumor is planned. For the first time, we have a promising maintenance treatment in metastatic endometrial cancer. These are my conclusions. Endometrial cancer have relatively high proportion of tumor mutation burden and MSI deficient mismatched repair tumors, providing a rationale for treatment with checkpoint inhibitors. The MSI deficient mismatched repair phenotype has emerged as a predictive biomarker for checkpoint inhibitor. A number of checkpoint inhibitors have shown clinical meaningful activity in MSI deficient mismatched repair endometrial cancer as monotherapy. Dostarlimab is the only IO currently approved by EMA, while it is also approved by FDA. The efficacy of checkpoint inhibitors as monotherapy and microsatellite stable proficient mismatch repair is limited, and there is room for improvement. Lenvatinib and pembro has shown superiority in terms of progression-free survival, overall survival compared to physician choice chemotherapy, and is FDA approved in non-MSI deficient mismatch repair tumors and EMA approved in all endometrial cancer subtypes. There are numerous checkpoint inhibitors trials ongoing, as I showed you, either IO alone versus chemotherapy, IO plus chemotherapy versus chemotherapy, and we are waiting the answer of the question, will IO replace chemotherapy in first line? Still, it is applied in second line and third line. We are now in the era of new treatment and real advances in the treatment of recurrent advanced endometrial cancer. And sorry for being late. Thank you for your attention.
Thank you, Professor Muhammad, for this excellent presentation. I think we are out of time and we are delayed, so we'll move for the next session.